Who has received a surprise balance bill? Anybody in here received a surprise balance bill? It's actually fewer hands than I would have been. Oh no, lots of hands. So for those of you who might not have been paying attention, Congress last December passed a major federal health care bill that to me is probably the most transformational piece of legislation since the Affordable Care Act a decade ago. So the No Surprises Act basically probably wouldn't have happened if not for the media covering over and over those situations impacting consumers and for consumers speaking out and consumer advocates. So we're going to talk about the surprise balance billing protections of that bill for the next 50 minutes. That bill does a lot more than just surprise balance billing, but that's the focus of this particular panel. So we're super duper lucky today to have three perspectives. Two perspectives came from Washington, D.C. all the way to Texas to see us, but we have Patricia Kelmore is an attorney, and I just mispronounced your last name, Kelmar, with U.S. PIRG, the Public Interest Research Group. She advocates at the federal level, but also they have 26 state-based organizations, and she's focused on, let me check my cheat sheet. She's the healthcare campaigns director, but she's focused on bipartisan solutions to high healthcare costs, which again, Dr. McCrary talked about on his presentation. So she's going to bring the consumer perspective to our panel discussion. And then Laura Klimpe is the general counsel for Blue Cross Blue Shield of Texas. Laura and I work very closely together. Prior to becoming general counsel, Laura was head of our litigation in Texas for Blue Cross, and she dealt primarily with provider disputes. And they carried that case all the way to Fifth Circuit, thank you very much, on prompt pay. So you health plans in the audience, pat her on the back later, because that was a super important bill in terms of impacting our industry in the state. And then my favorite actuary, economist, healthcare. I love actuary, so I can't help, I always say that. But my favorite healthcare economist, my friend Lauren Adler. I feel like I'm famous because Lauren is frequently quoted in the Wall Street Journal and the New York Times. He's widely considered an expert in healthcare policy and surprise balance billing. And Lauren is the associate director of the USC Brookings Schaefer Initiative for Health Policy. And his research focused on healthcare costs, prescription drugs, Medicare, and Affordable Care Act. And if you read the new federal rules on the new IDR process, Lauren's work was cited like numerous times in the footnotes. So he's like super famous, and now he'll be in history in the Federal Register as influenced the outcome of those rules. So what we're going to do is each of our speakers are going to spend about 5 minutes with an intro, kind of from the consumer perspective, the nuts and bolts perspective, and the economics perspective of the new surprise balance billing law. But I wanted to spend 2 seconds talking about why this is such an important issue in Texas in particular. I'm not going to go through all these dates, but the point of this intro slide is, one, I've been doing this a really long time. I just want to, on a side, I have been coming to every Texas Association of Health Plans conference since 1996. So if I had known I was spending half my life coming to this conference, I would have saved all my name tags. But that's how long I've been working on these issues. And the Texas Association of Health Plans in 2003 proposed some legislation to try to address surprise balance billing. Aetna, thank you Aetna, now CVS Aetna, put together this 5-inch notebook of paper claims. We still had a lot of paper claims, and they were all redacted, so you couldn't see member info, but they all were showing high inflation and costs for hospital-based providers. And the health plans were like, golly gee, we're having a hard time contracting with these guys, and their prices are going up. What are we supposed to do? And so we had a legislative proposal. It did not progress in 2003, but they spent the next decade, 20 years almost, talking about transparency. Maybe that'll fix it. And then they finally got to mediation. Thank you, Senator Hancock. He was a House member at the time. And then finally, in 2019, they passed our state-based No Surprises Act, the Senate Bill 1264, which was, to me, and I've done this a long time, was one of the most consumer-friendly pieces of legislation that Texas has passed in about 20 years. It created complete prohibitions against surprise balance bills for consumers in the state of Texas, but it's just a sliver, you know, for those fully insured people covered under plans that the Texas legislature could regulate. And so that leads us to where we are today. You know, we got that done in Texas in 2019, And then in 2020, Congress passed the No Surprises Act, which is huge. And so I'm going to start off with Patricia and let her tell us why was this so important to consumers in Texas and in the United States. So.
Thank you. So I'm so happy to be here today because this really is the most important patient protection that has happened for consumers in at least a decade, right? It's going to affect millions and millions of people, the protections that are going to become law in just a couple of months. So this has been an age-old problem, right? Millions of American insured consumers have faced the problem of expensive out-of-network bills that they had no way to avoid. And I thought it was important when we were preparing for this panel to just take a second and talk about, like, who are these folks? And let's remind ourselves, this isn't just a, numbers game or something. These are real people, and I think Dr. Macri had some really good examples of the impact on individuals. But so it doesn't take a lot to find examples of surprise billing. You probably have your experiences yourself, as we were just having you raise your hands. But it comes up, there are three pretty common areas. It comes up, first of all, in emergency situations, right? Like the one from David, lives in Austin, right here. He experienced some heart pain, chest pain. His neighbor took him to the hospital, the closest emergency room. And fortunately, he survived. He got the surgery and the stents that he needed. He was out of the hospital in a few days and recovering. But David remembers when he was in the hospital thinking about, what's the network status of this hospital? What am I going to have to pay? The hospital's like, don't worry, your insurance will take care of it. Unfortunately, it wasn't quite the case. A few weeks later, he receives a bill for over $108,000, which was his portion of the balance bill for the out-of-network surgery and the 4 days that he spent in the hospital. And of course, as a patient, after the fact, there's no negotiating, right? You receive the services, the bill is in your hands, and now you have to figure out how you're going to pay for it. Then, of course, we have, and the other thing, of course, is even though Texas has surprise billing protections, because he was not in a state-regulated plan, he was not able to take advantage of those protections. The other common area, surprise billings come up in situations where patients are doing all the right things, they're choosing that in-network situation, the in-network facility, and then unbeknownst to them and without any of their choices, they are given care by somebody who is not covered by their insurance network. That's the case that happens with Wendy, right? She's in her in-network facility where she's receiving cancer care, and it's all going well for the various treatments she's getting until the one day when she suddenly gets this surprise out-of-network bill for $10,000 from an out-of-network provider at her in-network facility. Again, not in a state-regulated plan, no protections. She's stuck with that bill. And then the third common scenario is the situation of emergency transportation, right? This is a situation where you really have no ability to pick who's going to bring you and who gets chosen to transport you. So in the case of Naveed, he's a radiologist who was out having some fun with some friends on his ATV, had a terrible accident, severe laceration of his arm. He actually had to create his own tourniquet to stem the bleeding. He was taken to the local emergency room, but they said, no, it's too complicated. You need to be transported to a level 1 trauma center. The hospital ordered the interfacility helicopter to come and transport him. He unfortunately was not able to save his arm after multiple surgeries, and so not only did he lose his arm, but he ended up paying, having a bill for his responsibility of over $44,000 in that interfacility air transport. So these are just a few of the examples. If you want to go to the next slide. I mean, the examples I've given you are showing you really what happens to the individual consumer, but you can see 1 out of 5 Americans are faced, if they go to an emergency room or have surgery, with a surprise bill. And the average surprise bill can be as low as, the average is about $600, but you've seen can be significantly higher. And then in the case of air ambulances, it can be about 40% of air ambulance surprise bills are $20,000 or more. So very devastating. Most Americans only have a few $100s in their savings account. These kinds of bills can really put them under and cause a great cascade of debt. So as consumer organizations, the Public Interest Research Group, TexPIRG, AARP, here in Texas, Every Texan, consumer organizations have been fighting for years for solutions, and we started at the state level. We ended up passing over 26 state laws, including here in Texas. So I just thought I'd give you a quick overview of the Texas law. It's right here, exactly the situations I've just been talking about, where the consumer is doing the right thing, doing what they can to choose in-network, but they have no way to avoid that out-of-network charge. The great part about the Texas law is actually this other thing, which we're seeing very common in other states, out-of-network lab or diagnostic imaging that's happening like in your in-network provider's office. They tell you, just go down the hall and get your blood drawn, and then it's an out-of-network bill. No idea, right? You went to your in-network provider. So Texas allows for protections in that. But as we've just mentioned, right, it's only for state-regulated plans, so most people are covered by, an employer-sponsored plan, and that is preempted from any state regulation. So we really worked hard to have a federal solution. So the No Surprises Act, right? So we luckily had some examples from the states to understand what was working and what wasn't working. And so as consumer organizations, can you go to the next slide? We had two primary goals. The first one is of course, taking the patients right out of the middle, right? Prohibiting the balance bills from being sent to them, taking them out of the middle of the dispute. But then it was also important for us as consumers to understand and know that if an arbitration is not designed well, it could end up passing on costs to consumers through either higher payments or overuse of arbitration. So we had those two goals, and luckily Congress came together in this, unusual bicameral, bipartisan solution to pass the No Surprises Act at the very end of last year, after years of fighting for it federally. And in 2 months, we are going to see how that gets implemented. So, thank you. The ban on balance billing on the federal level is very similar to Texas, right? For emergency care and for out-of-network services at an in-network facility. But then it goes beyond, and there's two additions. So first is the post-stabilization care, so that patients who have been brought in to an out-of-network facility because of an emergency, they can stay in that facility unless they're stable enough to be transported out and consent to do that. So that's one area that's going beyond. And then we were not able on the state level to ever regulate air ambulances. It was considered part of the FAA and federal law, so that states were preempted. So now we have air ambulance balance billing protections. The bill also goes on to provide patients the right to use the existing external review process to be able to challenge any violations of the No Surprises Act. So it's not quite like the private right of action, but it is an avenue so that we're not, if the patient thinks that the law has been illegal, there's a process for them to go through it. Next one, please. And also, of course, the law there's provisions for notice, so consumers are getting notice of their rights both in the facilities and then on their EOBs, and that will hopefully start to educate consumers about their protections. The one area that I wanted to point out super quick here is this issue of consent for out-of-network care. So it was always, we didn't want to remove all choice from the consumer, so if there was a reason that they wanted to have an out-of-network provider, there was going to be an opportunity to sign a waiver of your form and accept the additional charges of an out-of-network provider. The federal law doesn't allow providers of this, I have them listed here on the slides, of providers who can ask for that out-of-network consent, of waiver of your protections. And that's important because these are the situations where we're seeing, the potential for coercion, that patients would be asked, like, well, you kind of need your, anesthesiology, so just sign here. There has to be an opportunity for an in-network provider to be available to the patient for the care that they need before they could sign away their rights. The other thing is that in Texas, you have a great waiting period. These waivers of consent have to be signed 10 days before the service. Unfortunately, the No Surprises Act has a shorter window, so it's 72 hours before the care is given, and in some cases as low as 3 hours in the case where you might come in at the last minute and you're.
Can I ask you a question before you
Yeah.
go on to Laura, just to make it clear? So you're saying, so who's left if you're in the hospital? So the providers that can't get a waiver are the hospital-based providers, like, because you're in a nightgown already. Like, it's the ER, the anesthesiologist,
It's these ones
whatever.
cannot ever.
But if you're
right?
like someone else that provides services
Yeah.
at that hospital, but you're out of network, that's a planned procedure, you can.
You could order it.
Okay.
So, I,
So like
I
an
think of
assistant
like
surgeon,
I
or
think
are
of
they
like
on
the
exception list? Okay.
dog bite situation or
Okay.
something, right? So you could just get it stitched up,
Right.
but you might want to bring in a plastic
Right, a plastic
surgeon.
surgeon. Okay.
And in that case, if there is no in-network provider as plastic surgeon, then you wouldn't be able to sign away your rights. But if they had a couple of choices.
Okay.
Or there could be cardiac situations where you want the best,
Like, I'll
cardiologist.
let Dr. DeBecky, he's gone, but
Right.
the super special, I don't care how much it costs. I'm
Right.
like, the top dog. Okay.
Yeah,
Sorry, I just
there's
had
a
to kind of
choice-
clarify that. It's hard
There's
to
a
skip.
choice for the consumers,
Okay.
but the consent goes along with an explanation of benefits. I mean, a good faith estimate, right? So when you're signing that, you also are getting like, what are you expected to
Okay.
pay for it? So it can be good. We're just worried and want to make sure it's done well. Okay, so then just looking ahead. I was asked to just kind of say, what are the things that we're thinking about? So the states are the implementers, right, of this federal law. So for state regulators and federal regulators, we're really looking for strong consumer education and a one-stop hotline. So right now, the HHS is going to set up a hotline, but HHS has no experience really handling patient complaints. So we would hope that TDI would step forward, already have a lot of experience dealing with the surprise billing complaints that are happening right now, and shepherd consumers through. And also thinking about, for a consumer or patient, who are they, when they're in a hospital having a problem, they might be thinking health department, they might be thinking medical board. So wherever they call to get some help on surprise billing, we would want to see some type of warm handoff of, no wrong door, and getting them to the right hotline for their help. Looking at arbitration, making sure we're getting fair payments, and I talked about the consent form, and then of course the number one concern and a very common place for surprise billing is ground ambulances. We have neither state or federal protections for that. So
if you're around tomorrow, we have a breakout session on ground ambulance and why it's so complicated and why it wasn't included.
Exactly. So join me tomorrow and we'll have a great discussion because we need to find a solution to that. Patients are being, really, it's tough for them. So thanks for that. I look forward to the discussion.
Okay, so Laura is going to give us kind of the nuts and bolts, and so that we have time for questions on how the federal IDR process, independent dispute resolution, how that's going to work in the No Surprises Act, and the distinction. I mean, we can talk about that a little later. Many of you in the audience, we could talk about SB 1264 all day long, but which is the Texas state-based system. The federal system has some very different aspects to it. So Laura, do you want to kind of?
So I think Patricia did a great job explaining why this is a problem and what some of the solutions are that we see in Texas now. And what this slide gives you is a very high-level snapshot of what's the solution we got from the federal government. And as Patty mentioned, this little column on the edge here, those are a lot of other provisions that are in the No Surprises Act that'll be addressed in some other panels in this conference. Today we're focusing on this first big box. So I'll just give you an overview, some of which includes some of the really impactful consumer protections, as well as now how are the plans and providers going to sort out their differences. So as Patricia mentioned, there is no balance billing for the categories of services covered by the NSA, which is emergency services that have been defined differently in the federal law. We'll talk about that a little bit. Out-of-network services in a participating facility, as well as the air ambulance services, if they're services the plan would cover from a network provider. We've talked about the notice and consent process. There's some other claims provisions in the law that are new. There's payment deadlines, 30-day payment deadline from the point the plan has the information necessary to determine the claim. And patients or payments now go directly to the providers. Some payers do this already, but not everybody does, so no more member-directed payments. They will go directly to providers. And there will be different disclosures on EOBs for members, as well as some disclosures on the explanations of payments to providers about how cost shares were calculated and what applies to the claim. So let's talk about the emergency services for a minute. This is a change in the law that has expanded the scope of emergency services under federal law from what we're all used to today. To be clear, the prudent layperson standard remains in place. The prudent layperson standard has not changed. So whether or not a consumer or a member is experiencing an emergency condition is still assessed by the standard of, what would a prudent layperson believe? Would they think their life is in jeopardy if they didn't go get immediate medical attention? But what then is considered an emergency service subject to the Surprise Act protections once that person is experiencing an emergency has changed? So a couple significant changes are around the setting of services. So now freestanding emergency rooms are explicitly included in the definition of emergency providers in the federal law. For those of us who've been here in Texas, that's already been the case in state law, wasn't always the case in federal law. So now freestanding ERs are in for federal law as well. Additionally, for the services to stabilize a patient, as well as the post-stabilization services that Patricia referenced, those can be rendered in any department of the hospital, and that's explicit and new in the definitions. The second bullet point here, screening exams, that is unchanged from the current law. Screening exams are still considered emergency services performed in the emergency department or now a freestanding emergency room. So the setting in which emergency services can be rendered is a bit broader, and then pretty significantly, the scope of an emergency service in an out-of-network context has changed to include post-stabilization services. So think, for example, an individual is in a car accident, goes to an emergency room, gets admitted, is in the hospital for a month. They're in their inpatient for a month. Now you might be used to the emergency episode ending earlier and that claim just becoming a routine out-of-network claim for the inpatient stay. But under the No Surprises Act, some of that post-stabilization care continues to be treated as an emergency service and subject to the protections of the No Surprises Act, the no balance billing, and some of the dispute resolution that we'll talk about. There is a mechanism to end it, to have the patient agree and to have the doctor determine the patient is safe to be transported elsewhere. But these out-of-network post-stabilization services are a significant change in the scope of emergency services.
So what does that mean? Does that mean when they come into the ER, then the whole claim, are we gonna have a bunch of planned procedures at out-of-network hospitals that they conveniently go through the ER and then it's subject to this process, or the whole claim is gonna be subject to?
It still needs to be an emergency service that meets the prudent layperson standard.
Okay.
So, a scheduled knee replacement weeks in advance that comes into the ER would not be somebody who's experiencing an emergency. But it means those people who come into the ER experiencing an emergency who stay in that hospital post-stabilization, those can be emergency services. And there's some conditions around that in the law, around the plan has to cover it to begin with, the type of service, but it just expands the scope. And then two other significant changes in the No Surprises Act. One relates to how we're going to start calculating members' cost sharing. Most of us now are used to a process where whatever the payment is to the provider is used to determine what that member's cost sharing is. For example, if they have a 20% coinsurance, they're going to pay 20% of that payment to the provider, of that allowable amount. Well, that's been changed in the new law. So now the member's cost share is going to be calculated on an all-payer model agreement, if there is one. There's not one in Texas, so that's not really in play here. So instead, if there's a state law that sets a method for determining the amount payable on the claim, the member's cost share will be calculated on that amount. If not, then it'll be calculated on the lesser of the qualifying payment amount or billed charges. So for those of you who haven't been living this law every day, you may be thinking, qualifying payment amount, what is that? Well, it's a complicated new calculation that the law and the rules lay out to determine a median contracted rate. And it's by geography, by provider type, by specialty type, and by market type. So now the member's cost sharing is divorced from the payment to the provider and instead will be based on a median contracted rate, basically giving that member an in-network financial experience. And then that amount is applied to their in-network deductibles and out-of-pocket maxes. So at that point, the member's taken out of it, the payment's been made, they've paid a cost sharing based on what feels like an in-network number, but providers may still not be happy by what they're getting paid because the allowable amount is still determined by the plan. So that's when they can access the dispute resolution process that's set up by the law. It's a two-step process. First, if a provider wants to dispute a payment, or a plan can initiate it as well, there's an open negotiation period. So for a 30-day period after the claim is paid, the parties try to negotiate a new payment amount, see if they can come to an agreement. If not, the services can move forward to what Patty referenced, independent dispute resolution, or you've probably heard people refer to it as IDR. And this is what you may also hear, a baseball-style arbitration, where the plan will submit information about the services, the provider will submit information about the services, and then the IDR entity will pick a winner. They won't come up with their own number, but they'll pick.
Do they pick the number from the final offer? Is it like the Texas law? And for those of you who are following the Texas law, it's all on a portal with TDI, and we put our final offer in, and they put their final offer in, and the arbitrator picks one or the other. And then with Texas, you split the cost. But in this one, it's loser pays.
Yeah, this is different on cost.
It's got a little different impact.
There's a couple layers of costs on this one. The IDR entity fee for actually considering the dispute and deciding is loser pays. And those costs that came out in the last rulemaking range in the neighborhood of around $500 to $600, depending on whether or less, depending on whether the services are batched up or whether it's an individual.
But if you can
service.
batch them, then that's kind of a de minimis. So it's going to be, if you're going to make more money using the system, you're going to use the system. The fee's not going to discourage you from using the system, I would think.
The other fee that's minor in comparison is there is a $50 non-refundable administrative fee that both parties pay.
So I want to make sure we have enough time for questions, and I want to look to Lauren to tell us, what is this going to cost? What does this mean to cost going forward? Give us the economics.
Sure. Thanks for all the setup here. So I also, when we talk about this, obviously we get very into the technical terms very fast, but I always like to take a step back here and think about why the problem of surprise billing existed in the first place and why this is a bigger problem than just the surprise bills themselves. And Patricia obviously teased that as well, but fundamentally, right, the issue here is that for some reason we allowed separate contracting for the surgeon at a hospital and for the anesthesiologist, who is an integral part of that surgery, obviously. But we still have distinct contracting here. So it provides this weird model where the anesthesiologist can refuse to contract with the insurance company, but still see a lot of patients. And right, that doesn't exist for other providers. Most other specialties, right? If you're not signing in-network contracts, you're just not seeing patients. So that provides this effectively a alternative to negotiation that you can, it gives you leverage as the anesthesiologist here to sort of back out into negotiations and know you have this sort of option to, the insurer's still probably going to pay something on the out-of-network service, and then you can always go after the patient as well here. And right, I think we have a good amount of evidence from the economics literature at this point that the fact that market failure existed there, that this was possible, was increasing provider prices and was having an impact increasing premiums that we were all paying in the commercial insurance market. The exact estimate is a little hard to pin down, but that's where this really comes from. So then, right, the question was, how to solve it, and that's how we, I'll try to skim through here to get through, but that's how we ended up with the No Surprises Act, right? There are a lot of states that have passed laws, including Texas, over the last several years on this issue, but we ended up with the No Surprises Act, and I think the big way folks were thinking about this is that, this is largely a problem in emergency services and anesthesia and a little bit in some of the other ancillary hospital-based services where this is possible. But fundamentally, this seems to be driven by a small subset of those specialties. This isn't, right, most doctors do not want to send surprise bills to patients. That isn't like what people got into medicine for. So it really is driven by a subset. So the way that to think about the law, or I think how policymakers were really thinking about this is sort of an outlier problem. There's a 20% kind of problem here. And so really everything about the way the law was structured was trying to remove the impact of those outliers on what payment rates and what prices will be for these services going forward. So that was where everyone sort of came at this, and that is why really everything has focused on this median in-network price, or they somehow changed the name to the qualifying payment amount somewhere through the federal process. But fundamentally, just think of it as the median in-network price. And I hate how I have to get into this right away, but medians have the nice feature that it doesn't matter whether someone was getting paid $1 million if it was only 2 people getting paid that. That has no role in the median, right? That is just what the 50th percentile doctor in this specialty was getting paid for that service. So that is, right, we're sort of, if this was a 20% problem, those folks really aren't factoring into this qualifying payment amount or the median in-network price. And then to sort of drive that home, they then take that a step further in the way they set up this calculation, that it is actually based on, it's just sort of 1 unit for each contract you have. So even if you have a contract with a large emergency physician staffing company who is, 70% of the claims in your geographic market, they still count as 1 contract. So if you have a contract with 4 other emergency physician groups in that area, even they're the other 30% of the claims, it's that the third priced contract in the middle there that is the one that is setting the median, and that 70% of the market is having no effect on it. So it is really trying to reduce the effect of those outliers. Mm-hmm. And then in sort of the way, I think we've talked a bit about this arbitration process, and I think my view is, I think often for a lot of these types of specialists, like an emergency physician or an anesthesiologist, fundamentally their actual natural negotiation partner is really the hospital or the ASC or whatever the facility is. That's fundamentally that's who is responsible for the flow of patients that doctor is seeing, and hospitals obviously need anesthesiologists in order to make a lot of money.
I got to make it a point here that I forgot to say when we started, but Texas has 1 out of 3 out-of-network surprise balance bills versus the rest of the country. In the hospitals, when we used to bring them to the table over the last 20 years, would say, well, Texas prohibits the corporate practice of medicine. We can't help you with those doctors. So, there's all kinds of things in the law in Texas that made it a lot worse than other states. And there's another point. Texas has 200 freestanding ERs. These private equity guys aren't dumb. They came here, well, yes, we've got a lot of people, but they also knew there were a lot of plans that paid bill charges, and guess what? Whatever's on the bill, you're gonna get a check. So, there's a reason it was really bad here, and anyway, I just had to throw that in, because this law is gonna fix a lot of the market problems that we have, where there's not a free market. I don't know what the freestanding ERs are gonna do in the future, but they're not going to have that federal employee walk in and get a check for bill charges. So they're going to have to come up and do something different.
Yeah. No, and that's true. And fundamentally, most, obviously hospitals will say there's only so much we can do to really make our doctors sign network contracts. But most hospitals you talk to will say, effectively, we force our anesthesiologists to join the same networks we're in, right? That is pretty common, at least in most of at least they try, or we're going to be less likely to renew the contract after 3 years, sort of thing. Same thing with their emergency docs. Obviously, this is another sort of 80-20 issue where it is not every hospital, but a lot of hospitals all think of this and they're like, okay, well, this really isn't that much of a difference anymore. You talk to a lot of them and they get annoyed by this sort of I've got to rope in the cowboys on the emergency physician group, who's now this PE-backed group who is quite large and is sort of holding me over a barrel also. That is sort of my only to say that I think you largely can just sort of say, you could just sort of force this to be one negotiation and that would solve a lot of the problems here. But everyone sort of comes in and you need to sort of create some sort of minimum payment. And obviously for, the air ambulance or something like that, you really do need there's just not really a market for air ambulances. There's just no way to really have a functioning market there. So we've come in and then just basically said, instead of sort of naming an exact minimum payment we're going to force insurers to pay here, we're going to set up this arbitration process in this baseball style, but we're going to basically tell the process to largely base decisions on this median and network price, sort of other than extenuating circumstances. That's sort of the baseline appropriate out-of-network price, barring sort of other factors. And here's sort of like a coherent framework to think about what the price should be. And I think from my sort of econ perspective here, right, the more clear the expected outcome is in arbitration, the less it should be used. So if everyone just knows that the arbitrators are going to say whoever is closer to the QPA wins, you just don't bother going, because right, no one wants to take the risk that they're out the $500 or pay the $50 administrative fee. It is relatively small when you're batching a bunch of claims, but still, it's, you're only batching the same CPT code. So like, for some practices, it's at least not, it's 2% of the claims or something like that. But
so do you want me to move forward, Lauren? Because I want to talk about, I mean, the big fight is all about the QPA.
Yeah.
So I want to get to the TMA lawsuit too, because unfortunately, these big groups are not real happy that their contract just counts as one in the calculation of the median contracted rate. So there is a big lawsuit that was filed. Was it last week? So we jump to that. You want me to do a couple slides, or do you want to?
I can. The only thing I was just going to tee up at it's the last slide here, but
okay, let's do that, because I want to make sure we have time for questions. I want to talk about the litigation and for sure, and what the impact's going to be.
Yeah.
Which one do you want me to go? Oh, did I go the wrong way?
No, I was just going to tee up I think we can come back to this. So actually, the slide before also, just because this will factor into a lot of the discussion about the QPA, is that the Congressional Budget Office, who's sort of the Congress's scorekeeper, did make an estimate of what they expected the effect to be. And fundamentally, they were assuming that most arbitration decisions are decided at roughly the qualifying payment amount or the median and network price, right? That is fundamentally what was being decided. And that is the reason why this bill was expected to generate $3 billion a year in taxpayer savings and about double that in consumer savings. Counting your cost sharing and your premium reduction.
Super important, because for those of us in the Texas lobby, we live and die on fiscal notes. There's a fiscal note, that's the best way to kill a bill. So I've heard that the doctors are lobbying Congress to try to get rid of this reliance or presumption on the QPA, but there's a price tag if they do it, right? I mean, there's a reason they adopted the rules the way they did. And do we want to pivot to that? We have like 5 to 6 minutes, so we don't have a whole lot of time. This is a pretty heavy topic, and it's important. So I don't know if we want to jump in on the TMA lawsuit.
I can provide just
real quick on the TMA
lawsuit. On the lawsuit. So last week, TMA filed a lawsuit against the Biden administration challenging portions of the most recent set of rulemaking that came out at the end of September relating to the rebuttable presumption that the offer closest to QPA is what should win at an IDR. And they really have two bases for the challenge. One is procedural, that the notice and comment process should have been and was not followed in issuing that rulemaking, because if the IDRs aren't going to start January 1st, claims will come in, payers will have to pay claims, you'll have 30 days of negotiation. So IDR is not really a January 1 exercise, it'll be a few months in.
And it's on renewal. So unlike the Texas law that took effect basically data service 1/1 of 20, it's on plan renewal. A lot of big employers renew 1/1, so it'll be a lot of big ERISA plans will be subject to it, but some are mid-year or 9/1, so it won't be in an immediate. And so it's going to be a lot of confusion for providers and consumers, in a way, if they're even aware of this. It's going to be a phased in. By the end of next year, all plans will be subject to this prohibition. But anyway, sorry, I just wanted to clarify.
Just quickly, the other basis in the lawsuit is that the departments exceeded their statutory authority in adopting this rebuttable QPA presumption, because there's a number of factors that the statute outlines should be considered in IDR, not just QPA. And so there's an argument about whether or not there was enough basis to favor QPA over the other factors.
So Patricia, how do consumers feel about the TMA lawsuit?
Well, it's frustrating. I mean, we worked so hard to get here, right, and to get these protections. And, I've seen press coverage where TMA is saying, oh, we're not stopping the patient protections from going into effect. We're just worried about the arbitration. But as I had explained, we care about not only that individual patient being pulled out and not having that surprise bill, but we're caring about our premiums too. And if we have a bad arbitration system that is allowing inflated payments or high lottery-sized payments to providers, we're paying for that. We're going to be paying for that. CBO scored it as a savings. We're expecting to see that savings. In fact, it was scored as a savings that they already spent that money. So that money was spent in the last appropriation. So we need to capture that. It was anticipated it would be this way. The lawsuit is very troubling. Consumers have waited way too long, and we can't let this stop it from going into effect. So,
do y'all want to, because we just have a little bit of time, I want to make sure, I've already got an audience question right there, Ovik. Go for it.
Thanks, Patty. Anyone catch it, particularly Lauren, the impression I have is that the Texas state law is more provider-friendly and more price inflation-friendly relative to the federal law. Is that your assessment, number one? Number two, if that's true, wouldn't that create an incentive here in Texas for more people to move away from fully insured to self-insured products?
Ooh, that's a good question.
Sure, so that is a good question, Ovik. So, fundamentally, I do think probably the Texas law is going to end up at least somewhat more inflationary than the federal law, right? The Texas law tells people to consider the median network price, but also this 80th percentile of billed charges. So it's hard to imagine it ends up sort of better than the federal law. I also just like to say, if you are a state running an arbitration system, there is just a bureaucratic hassle of running two parallel arbitration systems with different rules. It's often going to be the same people who are actually doing the arbitration, but there's a pain for the doctors too. The doctors have to know which process to file through, right? I think there is just sort of like a big bureaucratic nightmare to this sort of aspect. On the sort of question of the fully insured versus self-insured, it's a little tough because I don't know how much doctors have a say in which patients they're really treating. I guess, nominally they might want to treat more fully insured patients in this world, but, it's generally the employers who are making the decision of whether to self-insure or not. And if anything, it's actually an incentive for the employer to self-insure to some degree. So you actually, probably even more so in a state like New York or New Jersey, where I think you even have more, some of the more inflationary laws out there. But so maybe more employers self-insure. It's only, I think 10% of your claim dollar is going to these sort of specialties where surprise billing is common, so it's not 100%, but
the volume, just so y'all know, I got the latest update, and I will give kudos to the Department of Insurance for actually creating an excellent online system that actually works pretty well. They told me last week the total volume since 1/1 of 20, and it took a while for providers to catch on, and so not only have providers learned how to use the system, there's now third-party vendors, surprise, surprise, that are filing on behalf of providers. 172,000 cases have been filed as of last week through the department portal. You can bundle claims, but the average is like 2 claims, so that just gives you, and if this is like 3 out of 10 patients, I don't understand where the federal government estimates on volumes came from, but whoa, Nelly. It's tough in Texas, and the way the system's designed, the providers typically win, and they're getting a pretty high return. So every time they submit a claim, they make money into the system. So it's not a surprise the volume is going up and up. So we're hoping this new federal system will maybe offset it, because 7 patients, you'll have more patients claimed subject to the new federal system once it's fully implemented than the state. So maybe that'll help with the negotiating leverage and get us back to something reasonable. Because what's reasonable? Is reasonable 300? Can I just mention, in 2003, our legislative proposal had to do with assignment of benefits, which no one understands. But at one point we pitched, just make us pay 300% of Medicare, and that didn't go anywhere. But how much should we pay? How much should we be paying, Lauren? Is this a lot of administrative costs for nothing? Can you just tell us, what should we be paying hospital-based providers? Because it's ridiculous. Really, this is where your healthcare dollars are going, folks. TDI did a good job, but it takes a lot of internal manpower. It's like 172,000 mini lawsuits, and you got to respond to arbitrators' questions. It's a lot of resources going into this. What should we be paying? And are we going to get to some normal, reasonable amount?
That's a good question. I don't know that I know it depends on the doctor. I don't think I know the right answer. Fundamentally, to my view is, if you just make surprise billing illegal and let the prices that result from the market come, you can get to a market price there, and that will vary, and that'll be swayed by market power and all of the bad stuff in healthcare markets in general. So I don't want to pretend that's perfect there, but I think certainly, right, we've already seen emergency physicians are averaging, getting paid 3 times Medicare nationally. Anesthesiologists are 3.5 times Medicare, right? So these are some of the highest paid specialties relative to Medicare prices for sure. Not that, Medicare prices are some perfect barometer, although are generally used as sort of a relative payment scale by plenty of health plans throughout the country in general. But
Alicia, do we have a question from the audience?
At the federal legislation, the way the QPA is calculated, is that based on kind of current year 50th percentile? Is that frozen in the past year, or is there an incentive to manipulate what the QPA might be going forward?
That's a great question. So it is tied to your contracts as of January 31, 2019. And then it is, so it never gets recalculated. It is just whatever it is then, and then you just inflate it forward by the like CPI, the basic inflation, forevermore. Maybe 20 years from now they come back to that, but at least technically, it's forever.
Got another question in the back.
Yes. One of the things that struck me in your presentation was the fact that the prudent layperson standard is still in place and unchanged and undefined. And those of us who have done managed care over time have really struggled with that. Is there anything in anybody's thinking about adding to the precision of what really constitutes a prudent layperson standard?
Well, one thing I'll add, there was some discussion around the prudent layperson standard in one of the rulemakings. I don't remember if it was July or the September one, around the use of diagnosis codes, which has been a sort of a hot topic for some time. And what the regulators explained is that the prudent layperson standard shouldn't be determined based solely on the diagnosis code and nothing else. There's other factors that need to be considered. They didn't really give any more detail or any more kind of color around that standard other than that. But for those who have been in the industry for a while, that's definitely been an issue that people have been watching. So I think kind of watching the rulemaking on this gives you a little view of where the federal regulators see it.
But think about it from the consumer perspective, right? I mean, we're alone when we're making that decision to seek emergency care. We don't have the advantage of knowing what a diagnostic code is or whatever. So to get beyond like a prudent standard from the consumer perspective is incredibly difficult. We want people seeking care, right? So we don't want people doing what they're doing now, which is when they get in a car accident, they like deny the ambulance because they know it's going to cost them, and they drive themselves to an ER. Like, we just don't want to be doing that kind of thing. So I'd be hesitant to kind of push back or define what prudent standard is. It's the consumer alone in that emergency trying to make the best decision.
One more question and then we'll transition to lunch.
Yep, so just really quickly, so we have SB 1264, right, along with 18 other states in this country that have provisions that are already in place. I'm wondering if you could add some clarity. My understanding is that the federal law offers stringent provisions. So in a state law, if the state law exceeds the federal provisions, the state law supersedes. So, Lauren, to your point, are we going to see doctors that have a varying of billing practices based off of the type of insurance that's coverage? Or do you see Texas, as an example, completely shifting to adopt the federal provisions?
I think Texas is pretty proud of their process. I can't see them giving it up. I think we're going to have two processes. Frankly, that's just a legislative interpretation, but
I mean, I don't think that's unique to Texas. I think most states are proud of their own laws, and it is, right, there's a pride of ownership that I think is difficult to overcome. But yes, so it's going to be quirky, right? Because it's only where it is more protected. So, right, so there's this basic split that the states regulate folks in fully insured plans, and then the federal law applies basically blanket to anyone in the self-insured plans, which is basically every large employer just self-insures, right? They're responsible for their own claims costs. But it's like going to be quirky, right? The post-stabilization stuff. So for a fully insured plan in Texas, right, the person who comes in the emergency care will be covered under SB 1264. I think I said that right. And the post-stabilization will be covered under the federal law, even for this fully insured patient. My view is I think a lot of states should eventually just sort of move towards adopting the federal standards, really just out of a simplicity aspect of this. Like, if your law isn't drastically different, right? The Texas law is pretty similar fundamentally to the federal law. Maybe 20 years from now, people sort of change their mind. But
I would much rather have the NSA but I like TDI's portal, but if we could get rid of bill charges and the calculation, that's crazy. So
well,
I wish you would
the
correct.
other good news is that there's going to be a lot of reporting and tracking, right? So in a couple of years, we'll start to understand some of the trends. And, I would urge, Texas to do its own level of reporting. Like, what questions you want answered. So get some reporting so that you can really look and see how this is all playing out, and you'll know then, right? We're probably not going to get it right the first time. Certainly consumers are going to be very confused, but it's something that if we're tracking and we're looking at complaints and we're understanding arbitration decisions, you'll start to know pretty quickly, I think, where
Facts
the
are
solutions
good. Facts are good. Okay, but it will be chaotic. It's going to be a
It will
chaotic couple years. It's going to be a mess for health plans and providers. Which channel, blah, blah, blah. It's going to be crazy, but it's great for consumers. So with that, we're going to wrap up for lunch. Alicia's going to come.
Yeah,
and
let's give
let
this
us
panel
know.
a hand.